Thank you for joining us. Please enjoy the event.
Good afternoon and welcome to today's webinar. I'm Elizabeth Dawes, Director of Maternal and Reproductive Health at the Century Foundation, a nonpartisan progressive think tank, and we are facilitator of the Black Maternal Health Federal Policy Collective, a group of Black women experts and policy professionals dedicated to the implementation of Black maternal health policy from inception to its implementation. Today, we'll discuss how changes to Medicaid and the Affordable Care Act included in the reconciliation bill will impact Black maternal health. For accessibility purposes, we have live CART and ASL interpretation. We will begin with a presentation, followed by a panel moderated by collective member Brianna Lipscomb. Before we get started, I'd like to add a few housekeeping notes. Please note that this event is being recorded and live streamed. If you'd like to submit a question for our panelists, please do so using the comment feature. Please welcome our presenters, Amani Eccles, Senior Manager of Maternal and Infant Health at the National Partnership for Women and Families, and Jamil Fields Alsbrook, Assistant Professor of Law at Howard University and Senior Fellow at the National Partnership for Women and Families.
All right, thank you, Elizabeth, for introducing us. My name is Amani Eccles. My pronouns are she and her. And again, I'm the Senior Manager of Maternal and Infant Health at the National Partnership for Women and Families. And I'll be presenting alongside Jamil, my colleague, and also fellow member of the collective. So almost a week ago to date marked the 60th anniversary of Medicaid. And instead of celebrating what the program has become, we were rather lamenting the current and future state of the program. The Trump and Republican budget bill that became law on July 4th represents the largest cut to Medicaid in the program's nearly 60-year history, significantly changing programs millions of Americans rely on. And the reforms to Medicaid and the ACA marketplace are estimated to decrease federal Medicaid funding by over $1 trillion and lead to 50 million people losing their health coverage by 2034. 2034 is roughly about 3 presidents from now, so there is opportunity to reverse course a little bit or prevent some of the losses, and we are going to discuss some of that today. But I will say the looming cuts are very real and are already impacting financial decisions by hospitals and states. Throughout the presentation, I will most likely be referring to the budget bill or the reconciliation bill as the budget bill. So just flagging that I will be using those terms interchangeably. So Medicaid is arguably the single most important lever for mitigating the nation's dire maternal health crisis. As the largest payer of childbirth services, Medicaid covers 41% of U.S. births, including 64% of births by Black birthing people. This is significant as the risk of pregnancy-related death is 2 to 3 times greater among Black birthing people compared to their white counterparts. And these statistics on the slide here really bring to life how the Medicaid cuts threaten maternal and infant health in every state and impacts everybody. Before diving into the specifics of the bill, though, I do want to zoom out and provide just a very brief overview of the Medicaid program to level set, and you will see that on the next slide here. So the Medicaid program is the largest insurance program in the United States, covering nearly 78 people. It's an entitlement program, meaning if you meet the eligibility criteria outlined in the law, you are guaranteed Medicaid benefits. The program provides health care for low-income families, pregnant people, children with disabilities, certain seniors, and those needing long-term care services. Many states have expanded coverage, though, beyond the minimum requirements at the federal level, such as increasing the minimum eligibility levels for children and pregnant women and expanding Medicaid eligibility to childless adults with low incomes through the ACA. And then finally, the program is jointly funded and administered by the state and federal government. The federal government provides financial support through matching funds, while states are allowed some flexibility in how they administer their program by setting their own eligibility criteria, benefits package, and payment structures, again, so long as they're meeting that minimum federal guidelines. On the next slide, you'll see that the federal law does require states to cover certain pregnancy-related services as essential health benefits without cost sharing. However, some pregnancy-related services, such as extension of coverage up to 1 year postpartum, certain midwifery care, and birth and doula support, are optional. And states are then able to choose whether they provide those services as a part of their benefits, and they do that through different policy levers like state plan amendments and waivers, Medicaid waivers. These optional benefits, which have been proven to improve maternal health outcomes, are sure to be on the chopping block for many states as they grapple with the unprecedented budget constraints imposed by the Medicaid cuts. And states that are not yet already offering these optional maternal health benefits are going to be even less incentivized to do so in this moment because of the budget constraints. So on the next slide, I will now actually start talking about what some of the key provisions that were in the enacted budget bill, but I will also preface the conversation by saying that the landscape is evolving. There have been judicial challenges, congressional efforts to repeal or counteract, mitigate the harm from some of the policies in the bill, and we'll discuss some of those efforts throughout. So starting on the next slide, some of the impacts to immigrant communities as it relates to Medicaid coverage. So prior to the passage of the budget bill, qualified immigrants were eligible for Medicaid after waiting 5 years. There was a 5 year waiting period. Qualified immigrants included lawful permanent residents such as green card holders, refugees, um, individuals granted asylum, Cuban and Haitian entrants, those granted parole for at least 1 year, and there's several other groups that fit into this qualified immigrant category. But the enacted budget bill restricts it so there are fewer immigrants in this qualified category that could be eligible for Medicaid after waiting those 5 years. So, for example, refugees and asylum seekers are no longer eligible for Medicaid even after waiting 5 years. The second piece I'd want to mention on this slide is that the budget bill also impacts the emergency Medicaid program, which provides much needed coverage for individuals that need health care regardless of their immigration status. This budget bill limits federal matching payments for emergency Medicaid for individuals who would otherwise be eligible for expansion coverage except for their immigration status to the state's regular federal medical assistance percentage or FMAP. Both of these provisions go into effect on October 1st of 2026. Next, on the next slide, eligibility redeterminations. There were changes here. Before the passage of the bill, Medicaid redeterminations took place annually, once a year, and redetermination typically starts with the state Medicaid agency sending a letter to the beneficiary outlining the redetermination process. The beneficiary then has to submit a renewal form back to the state. However, if a recipient moves and does not change their address with the state, or if they do not return the form by the deadline, they are at risk of losing their coverage and missing the steps to redetermine their eligibility. The enacted budget bill makes it so that states are required to redetermine eligibility for Medicaid expansion adults every 6 months rather than just once a year. This requires beneficiaries to jump through more administrative hurdles more frequently, resulting in more folks likely losing their coverage because of that. And 21 million people fall into this category. Next slide. There were also changes to retroactive Medicaid coverage. Retroactive Medicaid coverage is an essential um, benefit to the health of people, especially those battling serious illness. Retroactive Medicaid coverage is coverage for those with low incomes to receive treatment without having to worry about hospital bills piling up because they had not yet had the chance to apply for Medicaid. So imagine if you're uninsured, you get really, really sick, and you're in a health state where you're unable to go through all the administrative procedures to get your Medicaid insurance. Retroactive Medicaid allows you to then apply for Medicaid and retroactively apply it during that time you were sick or unable to apply for Medicaid. The enacted budget bill changes the retroactive Medicaid coverage from 3 months prior to application to 1 month prior. It reduces that window in which you could apply your Medicaid coverage to previous received healthcare. Shortening this time period just hurts those who are most vulnerable and aren't able to get their Medicaid coverage in time and will result in beneficiaries having more medical debt and could then even lead them to delay treatment and care due to cost. Next is work requirements. Work requirements, which I'm sure you've heard a lot in the news, force individuals to overcome a lot of extensive red tape to prove that they are most likely already working or qualify an exemption, or they risk losing their health care insurance. Most Medicaid enrollees who can work are already working, and that is especially true for parents. Approximately 6 in 10 mothers with Medicaid insurance are working, a rate higher than women without children, and another quarter are caring for their families. The budget bill would require adults applying for coverage or those enrolled through Medicaid expansion to work a minimum of 80 hours per month. Many people who should be eligible for coverage because they're working or might be exempt could be at risk of losing their coverage because they are unable to overcome the paperwork requirements to prove their employment or exemption status. And that has been seen in states that have implemented work requirements in the past. And it doesn't take a lot of research to understand that without access to Medicaid, if you lose your healthcare coverage, people will experience poor health outcomes that may limit their ability to consistently work and remain employed, preventing them from maintaining their health and economic security for them and their families. These work requirements go into effect January 1st, but states can seek a Medicaid waiver to implement them sooner. All right, on the next slide. So there are new out-of-pocket costs associated with Medicaid. This requirement marks a departure from the current rules that permit but do not require states to impose cost sharing on certain populations within limits that protect them from really high out-of-pocket costs. The enacted bill requires states to institute cost sharing up to $35 per service for Medicaid expansion adults. There are some caveats, like the out-of-pocket cost can't be more than 5% of family's income. And certain services like maternal health and family planning services are exempt from cost sharing. But overall, the enacted bill will dramatically increase the out-of-pocket cost for Medicaid expansion adults, um, leading to worse health outcomes as people delay care due to costs. And then lastly, within the Medicaid section, before I hand it over to Jamil to share a little bit about the ACA marketplace, is on the next slide, the provision to defund essentially Planned Parenthood and Maine Family Planning. I will say that the bill does not specifically name Planned Parenthood or Maine Family Planning. However, the criteria in one of its provisions clearly targets those entities because it prohibits Medicaid funds to nonprofits that engage in family planning activities, provide abortions outside of Hyde exceptions, and receive more than $800,000 in Medicaid payments in 2023. The provision was effective immediately and only applicable for 1 year. However, a week ago, a judge indefinitely blocked the Trump administration from enforcing the policy for all Planned Parenthood clinics. In other words, the judge's decision allows Planned Parenthood to continue receiving Medicaid reimbursements while the legal challenges to the policy are ongoing. This is a great win for Planned Parenthood in this moment, especially as a crucial safety net provider. 200 Planned Parenthood clinics were at risk across 24 states of closing because of this provision, but the preliminary injunction is only applicable to Planned Parenthood. Maine Family Planning filed their own case in federal court in Maine, and there's a hearing for the case in mid-August. There are also several other congressional efforts, bills that have been introduced that would repeal this defund provision in case the legal proceedings take a turn in the wrong direction and to add more protections. And now I will hand it over to Jamil to share a bit more about the changes in the ACA marketplace.
Thank you, Amani. Next slide, please. So there's a lot that could be said about how the ACA benefited pregnant and birthing people, and subsequently how any attacks on the ACA will impact this population. I don't have the time to do a comprehensive overview, but I just want to offer 3 points. First, the ACA expanded access to public and private insurance coverage. So the law expanded eligibility for Medicaid, as Amani was just mentioning, and essentially states were ultimately given an option to expand. But the law also provided financial assistance to both purchase coverage on the marketplace as well as to assist with out-of-pocket costs like copays and deductibles. And this has been particularly important for the maternal health crisis because we know that the crisis impacts people across the income spectrum. And so, as important as Medicaid is, we also know, though, many people in private insurance also are at risk as well. Second, the ACA improved the quality of insurance coverage for those who were newly insured and those who had existing insurance. And so it might be hard for some folks to remember, but before the ACA, some privately insured persons, particularly those who had to purchase their own insurance plan, so they were not a part of an employer-sponsored insurance plan, simply could not get coverage for maternity services. They had to purchase a separate, what's called a rider, which could cost as much as $1,600 a month. And of course, they had to plan to become pregnant, which is a whole other thing. And so the ACA changed this, requiring individual and small group plans to cover certain, quote, essential health benefits, including maternity and newborn care. And an estimated 13 million people gained access to these services. The ACA also required most insurance plans to cover certain women's preventive services, which HHS has notably interpreted to include breastfeeding services and supplies, and screenings for diabetes in and after pregnancy, as well as other important services like well woman visits and contraceptives. And there is yet another set of preventive services that also must be covered, and certain service, and that has been interpreted to include certain services and supplies for pregnant people, such as folic acid supplements. And finally, the law includes certain protections, including prohibiting certain plans for the first time, notably, from being able to charge women more for insurance coverage based only on the fact of them being a woman, and incorporating certain civil rights protections, like prohibiting sex discrimination. And so there are a number of studies that show that pregnant and birthing people had better healthcare access following the ACA. And this new reconciliation law threatens not only to eliminate some of the coverage gains that came under the ACA, but also move people into these lower quality insurance plans that don't include maternity services, as the world was before the Affordable Care Act. Next slide, please. And so I'll now just to quickly unpack some of the specifics around the reconciliation bill. So Amani discussed the impacts of Medicaid program generally, but the law also threatens to eliminate an incentive for states to expand Medicaid beyond the limited traditional eligibility. Traditional Medicaid eligibility required states to meet not only require individuals to meet not only state determined income eligibility, but also meet very limited categorical requirements, and the ACA eliminated the need to meet these requirements and set a minimum eligibility of 133% of the federal poverty level. And there are still 10 states that have not expanded Medicaid. And a few years ago, the states were given an additional financial incentive to expand their Medicaid eligibility. And we saw a couple states take up this option. Well, the law eliminates this financial incentive, threatening potential for the remaining states to expand. And we know those remaining states are disproportionately located in the South. Next slide, please. The law also allows for some premium tax credits. So I mentioned the premium tax credits, which help people purchase insurance. Those have been extended or expanded, excuse me, so that more people become eligible for them. And this reconciliation bill is allowing that expanded of the premium tax credits to expire. It's estimated that around 4 million people will lose their insurance coverage once these expanded credits expire. And what's more people likely do not realize that they even qualify for financial assistance because of this provision. And subsequently, there is no doubt that many don't even realize that they are at risk of losing their coverage. Next slide, please. Well, this bill in some ways is nothing if not consistent. And unfortunately, many of the same attacks on immigrants that we see in Medicaid also are moved over to the private insurance and the ACA. So immigrants, including those who are lawfully present, already have very limited access to purchase on the marketplace. And this law aims to make it harder. So there is currently an exemption that allows certain lawfully present immigrants whose income is below 100% of the FPL to qualify for premium tax credits, and the bill eliminates this pathway next year. The bill also goes even further in a couple years and prevents certain lawfully present immigrants, including refugees, from receiving premium tax credits through the marketplaces, and only very limited categories of immigrants will be eligible for tax credits. Next slide, please. And so the final couple provisions that I'll highlight here is that for those who remain eligible for coverage, the law also aims to make it more difficult to enroll in those high quality ACA plans that I mentioned. So first, there is typically only one time during a year when most people can enroll in coverage on the ACA marketplaces, except if a person qualifies for a period known as a special enrollment period. And because policymakers have previously recognized the need for people with low income in particular to enroll in coverage, those with incomes below 150% of the federal poverty level have been able to enroll in coverage year round. To put this in perspective, in 2025, nearly half of those enrolled in coverage would have qualified for this special enrollment period. And this law eliminates that pathway. And finally, the law also eliminates the ability for people to be auto-enrolled in plans, certain people, if you are receiving tax credits in 2028. If you think about it, many of us who have employer-sponsored insurance, you sign up and then you every year, unless you make a change, you get enrolled back in, and it makes the process so much easier. And this law will eliminate that. And so, I'll just close with saying I recognize that many of these changes can sound technical in nature, and it's hard to connect sometimes the real world impact. But a short way of looking at it is that many of the provisions that we fought back against in 2017 during the ACA repeal attempts, this law is just doing many of the same things around repealing and undermining the ACA, but just doing it under a different name. Next slide, please. Next slide. And so just overall, this bill will have an impact on people's personal finances. And it's it's only expected to get worse over time. Illustratively, as you can see here in 2027, people within the lowest income bracket will lose $165 in income. And this will change and increase to over $1,300 in 2033. And at the same time, we see that as they say, the rich will only get richer. Amani?
Yes, I can take us home here. You can advance to the next slide. This slide serves again to just summarize how devastating the losses will be. 15 million people are estimated to become uninsured by 2034, and the cuts represent an attack on the most vulnerable, an attack on health equity, and Black birthing people will bear the brunt of this. And then finally, I do want to just chat on the next slide a little bit about the impact on rural hospitals, because those health systems will also bear the brunt of the Medicaid cuts and the subsequent coverage loss by the patients that they serve. So it's estimated that there'll be $1 trillion in revenue loss to providers, and there will be an estimated $83 billion in uncompensated care. Those two things combined equal a lot more financial stress on hospitals and puts them at risk of needing to close or their labor and delivery units closing. This would make it so that pregnant patients have to travel farther for care, causing them to either delay or avoid medical care. That puts them at risk of not being able to treat urgent maternal health warning signs and puts them at greater risk of adverse birth outcomes. The national partnership conducted an analysis recently where it found that 136 rural hospitals in nearly all states across the country with labor and delivery units are at risk of closure or severe service cutbacks due to this budget bill. And the last point I'll make is that hospital closures are a perfect example of how the severe cuts to Medicaid and changes to the ACA marketplace will impact all people, no matter what insurance you have, because if there is no hospital, it doesn't matter if you have insurance or not, you're not going to be able to access care. And that is where I will leave us because I'm really excited to loop in experts on the call who are even closer to the issue that can speak a little bit more on the impact of the maternal health workforce and the impact on states. Thank you.
Amani and Jamil, thank you both so much for this incredibly helpful and comprehensive overview of the budget bill. I want to transition us to our panel discussion. And so as we get the slides taken down, I will go ahead and just introduce myself. I am Brianna Lipscomb, Senior Advisor of Maternal Health and Rights for the Center for Reproductive Rights. And I am incredibly delighted to share space and moderate this discussion today. So join me in welcoming our panelists, Representative Zakiya Summers, Mississippi State Representative of House District 68, Dr. Azza Nadhari, Executive Director and co-founder of Mamatoto Village, and then also our presenters, Amani and Jamil, will be joining us as well. So I'm going to move us efficiently through this discussion. Representative Summers, I would love to start with you. As I mentioned, you're a state representative from Mississippi. Mississippi, just in the past couple of years, implemented a 12-month postpartum extension for Medicaid coverage, which is an important step considering that Mississippi has one of the highest maternal mortality rates in the U.S. Mississippi is also a state that has not expanded Medicaid under the Affordable Care Act. And we know that this budget bill, as we just heard, is going to have major impacts on state budgets and state economies. And so I'm curious from your perspective as a state lawmaker, what are the impacts to community health and specifically Black maternal health that you're anticipating as a result of this bill? And would love to hear if you have thoughts on how states could respond to the consequences of these Medicaid cuts to better meet or to adequately meet the needs of their communities.
Well, thank you so much. I hope that you can hear me okay. Yes, great. Thank you all so much for the opportunity to join you on this panel. This is a very important topic. And I want to thank you also for the question. You know, we're talking about the One Big Beautiful Bill Act, which should actually be titled the Multiple Devastating, Declining, and Drastic Act because of the potential deadly impacts it will have. You know, it's just simply bad public policy. Many of the impacts stated in the presentation, we anticipate will hit us even harder here in Mississippi. We already lead the nation in infant mortality, and maternal mortality among Black women is roughly 4 times higher than among white women, with more than 80% of pregnancy-related deaths occurring in Medicaid recipients. Not to mention the fact that Black women face healthcare bias and lack of resources here in Mississippi. So the reconciliation package will only exacerbate long-standing structural inequities in one of the country's most vulnerable states. The new rules around work mandates and redetermination will kick thousands off of Medicaid. And we can't forget, as was stated in the presentation, that the majority of adult recipients on Medicaid in Mississippi and across the country are already working. So these mandates are not only necessary, but they create red tape that will result in many people losing coverage. The exact number of Mississippians who will lose coverage is still uncertain, but the Urban Institute predicts about 143,000 Mississippians will lose coverage. In addition to that, a recent Clarion Ledger article reported that 8 rural hospitals in Mississippi are at risk of closing. These hospitals are serving high percentages of the Black population. So we expect an increase in uncompensated care costs for rural hospitals and access to care to be significantly reduced, which will cause, you know, interruptions in care or discourage Black women from seeking timely care altogether. And then lastly, Mississippi has made strides in the maternal health space. As you mentioned, Brianna, last year we passed presumptive eligibility. The year before, we extended postpartum Medicaid for from 60 days to a full year. As you've stated, we still have not yet expanded Medicaid eligibility to adults. And the removal of the incentive that was talked about during the presentation, I think makes that even more farsighted. So the bottom line is that this act also puts the progress that we've made at risk and makes Black maternal health even more vulnerable. And it's going to be extremely important in how we implement the provisions set out in the budget bill, as well as the work that we do to safeguard these policies and strengthen systems that provide access to care. And what's even more concerning is the fact that Mississippi eliminated its income tax this past session, which is going to significantly reduce our revenue. So in regards to your question around how states may respond, I think it is inevitable that states will need to reallocate budgets in a way that offsets the negative consequences laid out in the budget bill. And for Mississippi, especially with the loss in revenue that we expect as a result of the income tax elimination. So, you know, for Mississippi and other states that have implemented vital policies like presumptive eligibility, postpartum care, that means that we continue to offer that coverage for new mothers for 12 months postpartum and protect presumptive eligibility. I think there's also some opportunity to oppose work requirements and frequent eligibility determinations for pregnant and postpartum people. And we have to increase safety net programs that support providers and keep our FQHCs, rural hospitals, and maternal health clinics open and thriving. Now, on the other hand, and I'll wrap up here, for states that will fall in line with these drastic cuts, many of these red states that are run by Republican governors and have supermajority Republican legislators, we could actually see deeper inadequacies, you know, where people won't have access to care, where health facilities will end up closing, and where it will be even more dangerous to have a baby and raise a child. So, you know, the budget bill is truly one of the most consequential acts that we will see in our lifetime.
Thank you for that. I can't help but it's like have this reaction to you talking about even deeper inadequacies and access to care, because we know that the current system is already inadequate, and seeing us moving in the wrong direction is deeply troubling. Dr. Nadhari, I'd love to bring you into the conversation as a midwife and through all of your work that you've been doing at Mama Toto Village. I'm curious if you could go into a little more detail about, from your perspective, how will, the service delivery that birth workers, give to pregnant people all the time and pregnant people's access to care, how will that be impacted by these cuts and changes to policies, both under Medicaid and the Affordable Care Act more broadly? And then I think a second piece to that, just because I know we've been doing tremendous work to expand the perinatal healthcare workforce, how do you see these rollbacks in funding impacting our ability to increase the number of Black midwives and doulas and other providers in the space?
Yeah, thank you for that question, Brianna. I'm not going to restate all that was shared by Amani and Jamil, but what I will say that this isn't just a policy issue, that it is creating and exacerbating a public health crisis. I really think that the question really needs to be posed of like, who are we as a nation if Black and Brown people cannot thrive, if they are deprived the human right of healthcare and education? And really, the same bill that cuts people off from Medicaid also makes sure that there won't be anyone to care for them, even if they had coverage. And so we can't dissect those two things that are emerging out of this particular legislation. As everyone has shared, this bill is gutting, right, the two main lifelines for pregnant people, Medicaid and the ACA. And when we look at birth workers, when we look at midwives, the people who are on the ground providing the care, what this legislation is doing is not only is it ensuring that people are losing coverage sometimes mid-pregnancy because of the paperwork hurdles and the redetermination and work requirements and all of the other things, but it is also really setting up for fewer providers to accept Medicaid, which is already a challenge because of reimbursements and the low cost of reimbursements related to Medicaid. It's also threatening our community birth centers as well. Again, opening up the pathways that these safety nets that are baked into the community won't have the resources that they need to keep their doors open. It also sets midwives up to lose clients. That if people cannot have a sustainable income as a midwife, that means that not only can you not take Medicaid, but you have to move to a place where you're only accepting private out-of-pocket pay. And then that then creates a disparity and access to who gets to have a midwife, that midwives become a luxury and not something that everybody should have access to if they are eligible for that. It also sets it up for people to be forced out of the field, right? When we talk about sustainability and burnout in the profession. Linking this to education and how this impacts the workforce. If we are to grow the workforce, right, we know that this particular bill also sets it up and makes it almost nearly impossible for people to pursue higher education at a graduate or professional level. And so not only is it eliminating or severely restricting access to those graduate plus loans and those professional student loans, which for sometimes is the only way that people can pay for their education. I would not have been able to finish my doctorate without that graduate plus loan. And I know so many of my peers are in that same place and space. We also know that many aspiring midwives, advanced practice nurses, lactation consultants, right, non-traditional students, they may be parents or caregivers or career changers, they need these plus loans. And then we look at the parent plus loan restrictions, which we know will worsen intergenerational poverty. As a parent with a college age student, I relied on plus loans to fund that gap. And so people who are sending their children off to start careers in healthcare, families need those plus loans to be able to fund that education. And we know that this is going to have a drastic effect on Black and Brown families who already face wealth and income gaps. And so, again, we cannot build a representative workforce when the cost of entry is rigged, especially against Black and Brown people from the start. And we are, going to need to push back against this. We're going to need our funders to step in. We need the philanthropic community to show up in ways that are going to fill these gaps until there's other legislative action and advocacy that can undo the harm that this bill is perpetually setting us up to have.
Thank you for that. One of the things that I think about as I hear you speak and Representative Summers and also our panelists, our presenters from earlier, so I want to bring Jamil and Amani into this conversation as well. We talked a lot about the provision of care, access to care as it relates to maternal health, which is incredibly important. But we also know that maternal health outcomes are driven by much broader impacts than just the actual service delivery itself. And so I'm curious, in addition to the changes to Medicaid and the Affordable Care Act, and feel free, anyone can respond to this, how do you anticipate this budget bill impacting the broader landscape of maternal health beyond just the service delivery in health settings?
I'm happy to kick us off because Azam, Dr. Nahari, sorry, Azam, made an important point connecting the dots about student loans. And just to be very clear, it was just only in the interest of time that we focused on the specific provisions related to the healthcare system. But we know maternal health outcomes are the result of a broader interlocking systems. There's also provisions around SNAP in the bill, so food assistance. There's already a number of places around the country that have food deserts, and that disproportionately impacts Black people living in rural areas, Indigenous people, and it is estimated that recipients will lose hundreds of dollars in benefits. I'll just say one other thing that relates to healthcare, but it's not specific to this bill. That in addition to, so this is an act of Congress, but we also have a lot of, I call them paperwork changes that the administration is making on the back end, including a number of other provisions that they're going to exacerbate some of the things that I mentioned related to the Affordable Care Act. So just one quick example, they also have a regulation to add additional barriers to enrollment. So I mentioned a couple of them, but for us who are in this policy world, we're looking at different provisions, who did what, but really what ends up happening for the individuals, it doesn't matter where the change came from, they're just going to feel the impact.
I also wanted to lift up too, going back to your question, is that this really is about pulling an ecosystem, right, and a safety net out from under Black maternal health. And as Jamil mentioned, right, SNAP cuts mean pregnant people cannot afford nutritious food. That is a birth outcome. Housing insecurity caused by funding rollbacks, increased stress leads to preterm birth. That is an outcome. Exposure to mold, right, in poor housing because of low housing stock, that is a birth outcome. If education cuts lead to our impact in our ability to train the next generation of perinatal health workers, that is a birth outcome. So I think it's really understanding the intersections that this bill has within maternal health. They may seem that they're siloed or parsed apart, but everything comes back to how is this going to impact this pregnant person, that mother, that caregiver, that father, that partner, right? How is this whole family unit going to be impacted, not just for the here and now, but we know that impacts that happen during the perinatal period ripple across generations. And so I do think that we can't think about impacts today. We have to think about how is this going to impact the people who are negatively living in this moment from this legislation? How is this going to impact them 10 years from now, 20 years from now? And so I do think that our approach has to have that consideration in mind, that it is that serious, that it is that dire. It's not about the win today. It's about the impact of this legislation for our future.
I'd like to add to build on the point that this is an ecosystem. I've been thinking a lot about the ripple effect that the loss of Medicaid coverage will have on other essential maternal health programs that families go to and rely on. So you can think of home visiting programs, the Title V Maternal and Child Health Block Grant, Healthy Start, which is a community-based federal program that addresses infant mortality in the areas most in need that are led by Black women, led by the people from the community themselves. And those programs are going to have to tend to and fill the gaps that will emerge because of the loss of Medicaid coverage, which would then put financial stress um, on those community-based organizations that administer Healthy Start programs and increased reliance of families on those programs, which to me, I feel like is going to be significant on those community-based organizations and their longevity and being able to meet greater and greater need over time.
You know, those intersections are real. And I'll just add that I recently read a statistic that said that nearly a third of childcare workers are covered by Medicaid. And so if workers within our childcare centers don't have healthcare access and they're not coming to work, that's going to be detrimental to single moms and families in general who rely on childcare so that they can go to work and take care of their families, which will then have a devastating impact on our economy as a whole. And so if our parents and our families are not able to go to work to take care of themselves and their children and their families, then they in turn are, not equipped to focus on how well their child is developing, how well their child is learning at school. And so the rippling effects will continue and will end up hurting economies, not just in Mississippi, but economies all across our country.
Thank you all for that. I mean, before I go into my final question for you all, because I do want to make space in case there are any questions from our viewership. If you have questions that you want to drop in for the panel, please do so using the comment feature, and we'll try to get to as many questions as we can. But building off of, all of you and your responses to this last question, and I can't help but think about just how comprehensive, how far-reaching the impact of this budget bill is going to be. And some of those impacts we will see immediately. Some, as Dr. Natari mentioned, will be kind of these long-lasting effects that may not actually manifest until later. And then there's also technically some pieces of the budget bill that won't even take effect until the next couple of years. And, I sit in the advocate space, as many of the folks that are watching right now do. And I'm just curious if you all have thoughts or ideas, suggestions on what advocates can be doing right now in this moment to push back on these harmful policies that we may not see the impact, or we may not even see them take effect for a couple of years. Like, how do we advocate in a moment where it's not tangible just yet? What can we be doing?
I'll start. We may not have $1 million in a PAC fund, but we have people, we have stories, and we have what we know is truth. And I think that what we can do is build narrative power and tell the truth that these cuts are not neutral, that they are targeted attacks, call them what they are, on the survival of Black and Brown people. They are targeted attacks on our immigrant populations. And really, they are targeted attacks on human rights, right, and reproductive justice. That there can be organization at the state level. There may not be as much movement on the federal level, but we can organize and mobilize at the state level and really push and force the people that we have elected who made promises that they need to make good on, elected them into offices and demand that they speak up and they create local safeguards and local safety nets, that we can mobilize around storytelling and gather testimonies from families and providers and students who are impacted by the fallout of this. And then we can continue, as Amani mentioned, nonprofits have always backfilled mutual aid in the community. That has always been a case. They have showed up where there have been gaps and failures in our federal and local government. And where policy fails, community always is there. Community has always showed up. And so I do think, as I said earlier, that we have to fund the gap, that the philanthropic sector truly needs to show up right now. They don't need to deprioritize racial justice and birth justice, but they need to double down, and they need to not be afraid. We need providers to step up and defend care, to stand on their oath to do no harm. And this movement right now requires collective resistance. It cannot be Black Black women who are at the front lines once again, putting our lives and bodies on the line for this whole country. It has to be everybody standing, pushing back and pushing forward against dictatorship, against white supremacy. And I truly believe that hope lives in the people who won't be silent, right? And every doula that's showing up at a birth to support that family, maybe not getting what she is owed or deserved, and every person who is starting their journey to be a midwife, despite the odds, I think that we have the resources on the ground to mobilize. And I think that we're going to have to activate in a way that maybe I think this is our movement. This is our generation's movement. Our ancestors had theirs, and this is ours. So we got to be willing to take that torch up.
I want to emphasize the point of storytelling and making sure that there's unified messaging in what we lost and who took it from us. I think a lot of the provisions that Jamila and I walked through, a lot of them go into effect after the midterm elections, and strategically so. So by the time the headlines simmer down, it doesn't impact necessarily Republicans' public approval rating going into the midterm elections. And so I think, again, it's really strategic for them to wait to take away people's health care as significant numbers after the midterm elections. And so it's really important that now and a year from now that we're able to all champion the same messaging again about what we lost and who took it from us. Um, and there Given the fact that a lot of these provisions don't go into effect until several years from now, there is some time to be successful in some efforts to either repeal or mitigate some of the harms of the provisions. And I will say that there's a few different bills that have been introduced that attempt to do that. And so I think it's really important that we continue to reach out to our legislators, thanking them if they voted in opposition of the bill, and then if they didn't, informing them of why they should support these other measures that have been proposed.
Thank you for that. Amani, I do want to just follow up with what you just mentioned because I am starting to see some of the questions coming in from the audience. And one of them is, what is the road ahead for federal policy, especially with what's happening now? How can folks advocate at the federal policy level? And what I've heard from all of you, honestly, is this whole storytelling component and how we can amplify what's happening and the impacts that people are seeing. But it also sounds like there are some solutions, some potential fixes that have already been proposed. So Amani, I welcome your thoughts on this, but also anyone else that has insight.
Yeah, the first that comes to mind is the Protecting Healthcare and Lowering Costs Act, led by Senator Wyden, that repeals the aspects of the reconciliation bill and extends the ACA advanced premium tax credits. So that is one bill that we encourage folks to show public support for. And then there's also the last thing I'll mention on that point is that bill also includes a provision to repeal the defunding of the Planned Parenthood that I mentioned earlier in the presentation. And there's an additional effort also to repeal that provision. There's a bicameral bill called the Restoring Essential Healthcare Act that also seeks to repeal that specific provision. So there have been efforts to counteract some of these provisions. And I'll also mention on the rural healthcare piece, I didn't have enough time to share this in the presentation, but in the budget bill, there was a rural health program that was slipped in there that attempts to support rural hospitals by distributing $50 billion over 5 years across all the states. There are a lot of reservations about the efficacy of the program and how much it will actually support rural health systems. But there have also been subsequent legislation that has been proposed to try to support rural hospitals. But I will say, definitely be, you know, read the bills closely because not all of them will actually be successful in what they're saying they're trying to do.
Can I just quickly add
Mhm.
another federal opportunity and just mention one point about the states? So one, I mentioned sort of quickly going through the presentation that the extended tax credits. So that's one of the first pieces up. They expire at the end of this year. So lawmakers need and should be taking action right now to extend those tax credits. You know, it might sound like just a wonky thing, but again, if you don't have the tax credits to help pay for insurance, then many people, estimated 4 million people, will lose coverage. There's also, as Amani mentioned, a number of bills, even from some lawmakers who shall remain nameless, who voted for the rescissions. And, you know, while we want to fix some of the problems they cause, we want to make sure also that we see you and we know that you both created the problem and now want to offer the solution. And then the final thing I'll mention is just about the state piece. So, you know, states are going to be put into a very hard a tough situation, and you don't want to minimize that. But at the same time, as states are making these difficult decisions, so for example, if states lose Medicaid funds, they'll have some discretion about what maternal health services to include, whether or not to extend their postpartum coverage. And I hope all of us are at that, have a seat at those tables to make sure that pregnant and birthing people have someone represented as decisions are being made.
Can I lift up one more thing too? I think the I think the other federal opportunity is that elections have consequences, and if the people that we have voted into office are not working on behalf of our interests, they need to be replaced. And so midterms are coming up. And if you know that this person has made empty promises, they have given blank checks, they have not delivered on the things that are necessary, or they have moved in service of white supremacy and maintaining that system, they have to go. That includes everybody across race and gender spectrum. I think that there comes a point where we have to demand more of the people that we have put into office. Like, this is a public service job. This is not a lifetime appointment for a seat. And so I think that we have to approach it that way. That these are humans and these are people, these are neighbors, right? And I think that we just have to remember that our elected officials are working for us. They are working for the people. And if they are not working for the people, then we do have to demand something different. We can't keep moving in the same way, having the same people hold office for 20, 30, 40 years, and they are not operating in any movement towards justice, liberation, or anything that is in service of Black and Brown people. So I do think that that is the federal opportunity. We can do all of these policy things. They are wonderful and we need policy, but we also have to get better people in these jobs.
You definitely need to make sure that you're registered to vote, that you get out and vote in every election. And we always say that all politics are local. So if you don't know who your state legislator is, get to know them, find out how they're voting. This spring, we held a news conference to acknowledge Black Maternal Health Week with advocates like the Mississippi Black Women's Roundtable and women from all across the state. This fall, we plan on doing a legislative hearing. These are opportunities where advocates and citizens can come to the table and voice their opinion about the issues that we're discussing, but also on the policy proposals that we intend to prepare for the 2026 legislative session. So I encourage the listeners to get involved. This is a good first step with having this talk today. And I want to thank again the collective for having this conversation.
Thank you all so much for just this rich discussion. I know we did not get to all of the audience questions. Hopefully we can have some follow-up conversations to address some of these pieces in more detail. So thank you to the audience for attending the event. A special thank you to our presenters and to the Century Foundation for hosting us. And a major thank you to the Black Maternal Health Federal Policy Collective Stay connected with us. You can use the link in the chat, or you can reach out to us via email at collective@tcf.org. And a recording will be made available immediately following this webinar on tcf.org. Thank you all so much for your participation.